All right, good afternoon. I'm Dr. Duke Majan, and we're at the Duke Spine Institute getting ready to perform endoscopic spine surgery on a patient who has two herniated discs, one at L4-5 and the other one at L5-S1. And the L5-S1 disc herniation is large, very large, one of the bigger ones we've ever dealt with. For some reason I feel like on the x-ray, let's take another picture, we're off on WAG a little bit at 5-1 and orbit. You see that? Look at the pedicles of 5. They're out of alignment. Shot. That's worse, I think. So she has a little bit of scoliosis, and before I go any further with my needle, I'm going to try to get the lateral view better. That's actually pretty damn good on the pedicles of 5. You had to come further south, huh? Huh? You want to optimize it anymore, or what? Why don't you try to get that fluoro a little further north and give us a good picture. So the first thing you have to do in spine surgery is you have to get your navigational information and equipment set up properly. That's your fluoroscope, x-ray machine, and you want to make sure you test it and you have good alignment, which we now have. That's really good. I think that's as good as we're going to get. Once you've done that, then you can actually navigate to where you need to go. Without doing that, you can't navigate. Shot? Because you won't have reliable navigational information. Shot? So right now we're trying to make our way, shot, down to the L5-S1. Shot? Are you comfy?
How are you doing?
Shot?
Okay? You doing okay?
This is the worst of the two discs by far. Shot? Let's get an AP. So her L5-S1 disc herniation is massive. She has a large annular tear posteriorly on the left side. She has a very large paracentral lateral recess foraminal herniation at L5-S1. And these are definitely the hardest to get to. So we talked about open back surgery. She didn't want it. I didn't recommend it as being better than this, but it was an option. She wanted the endoscopic procedure, which I think is the very best way to fix this problem. Sometimes we get into issues with a high iliac crest or an anterior spine. In her case, it looks like it's going to work out pretty well. Are you comfy? Little num-num.
You okay?
Our patient is laying on her belly.
Any pain?
Giving you some more numbing medicine, okay? Don't be upset. I'm just giving you an injection. Just like the dentist would tell you, they're injecting numbing medicine into your teeth so it can fix a cavity. We're doing the same thing here, letting her know everything's all right. We're just, huh?
This is a lot easier than the dentist. That's for sure.
Well, thank you.
Oh, yeah. I'm an extreme dental phobia.
You have a dental phobia, really?
Yeah.
Me too.
The worst patient in the world. That's true. I have white apples the whole time. It's a roller coaster.
Why do you not like the dentist? Incision? No, really, why don't you like the dentist?
Bad reflex.
Oh, so,
The x-rays. Top of my feet. They're like, they look
The x-rays?
good.
really?
Yeah.
X-rays hurt so bad.
Oh, those, when they stick that thing in?
Yeah, I get a bite really hard.
Yeah, it does hurt.
Like that.
You're right, this is a lot better than being at the dentist.
I had a root canal for my friend. It was a well-known endodontist. He said I was the worst patient in the history of his 20-year practice.
Really?
That's what he told me.
They tell you that
It's like one of my best. It's not gonna hurt. It's not gonna
Or
hurt.
like,
you actually just
or
go
do you
deep
ever have?
and hurt, and I was like, I'm done.
I know.
Done.
Or if you have like sensitive teeth and they start spraying that cold air, like the cold water.
The smell is what really is.
Yeah.
Smell.
All right, I got
What smell?
Let's not
When
talk
they,
about it. I'm starting to get sweaty.
Are you getting diaphoretic?
Yeah.
when they use the drill,
Oh, the drill smell.
Get
yeah.
the drills.
Well, with the
Shot.
I'm gonna pass out.
Dr. B's
it
getting
just gets in your
hyperactive.
face because they don't protect the face. It just gets all over your face. And I'm like,
Wait a sec. They ship. Wait. Oh my God. Let's stop talking about it. All right. So at L4-5, where the needle tip is, show the needle tip. I can actually feel the herniation. I'm inside of it, and we're going into that disc. So we're almost ready to put her to sleep. I'm going to just verify the source of pain. Shot. How much back pain did she have? Guys and gals?
6 months of pain
6 months.
and a lot of numbness and tingling in her legs.
So lower back pain, lower extremity symptoms, numbness, tingling, weakness, 6 months.
Yeah, couldn't really walk that well.
Yeah, her posture is amazing. She's so bent over. She can't even walk, the poor thing. She literally came in hunched over like that character. No, I'm not going to say Quasimodo. It's horrible. But you guys know what I'm talking about.
Notre Dame?
Fine.
bend over.
All right. Are you okay? She awake enough?
Yeah, try not to move your head, okay?
I need to know if she's responding.
You doing okay? Huh? My friend? You doing all right?
Hey, honey.
She said yes.
All right. Is she really ready for the test?
How are you doing? You okay?
yeah.
All right, we're going to do a little test here, all right? You have to give us a score, 0 to 10. All right? How are you doing?
Maybe she's too sleepy, too comfortable. You've done too good of a job with your anesthesia. All right, let's see.
I wish I had me in the dental chair.
Ah, there she goes. How bad is that on a scale of 1 to 10?
Give us a number.
Shot.
What number?
10? Is that where you get your back pain?
Is that where you get your back pain normally, hon?
All right, so do we have the lights on properly for this? Would you?
Yes.
No, you're fine. Whatever we normally do. So she has a big herniated disc at L5-S1. Okay, and she has a smaller herniation at L4-5. But the jelly from the center is stuck out through the tear. It's literally this big. It's huge. And then at L4-5, it's about a third of that size. Okay, so we just tested the L5-S1 disc and it's causing her pain. 10 out of 10 concordant. Is that better?
You doing better?
Yes.
Yes.
How bad is that on a scale of 1 to 10?
10.
All right. So 10, is that where you get your back pain typically?
Yes.
Yeah. Thank you. You get to go to sleep. When you wake up, we'll be done. Let's go to the lateral view. Show us the 2 tears in her discs. You can see how big they are. There's L4-5. Show them the whole thing, the whole tear. It's all the dark material. Okay, that's the tear. No. Go back to the L4-5. Okay, the tear, the bottom of the tear is go a little bit in towards the disc. Stop right there. That's the bottom of the tear. Go up. That whole thing there out to the side where it has a little pointy tip like a missile, that is the tear. Show them the tear. Outline it. That's not it. There you go. There, up higher. There you go. That's the tear. It's huge. Show the dye behind it in the epidural space. See that? Now show them the herniation. Part of the herniation, the bulge. No, that's a tear. Show them the actual, yes. See the negative shadow there? Yes, it's white. That is the herniation at 4-5. It's big. It's a bulging disc, herniated disc. And then at 5-1, the dye is already mostly gone. So it's too late to do anything down there. But you get the idea. She's got abnormal disc with annular tear, bulging disc, herniations, and horrible back and leg pain. And she came in to my surgery clinic hunched over, literally bent over forward like 90 degrees at her waist. She couldn't stand up because she was in so much pain. And the pain she was having was in her back, but also going down her leg. She had sciatica. And the way people with sciatic pain cope with it, they bend forward. So you see those people at the grocery store, they're like bending forward on the shopping cart. Let's have some num-num. Shot. I'm going to give her some more numbing medicine just to keep her comfortable. Shot. So as I go deeper with my dilator, I'm adding more numbing medicine into the muscles and fascia just to keep her comfortable. Shot. All right. Right about here, I can't add any more after that. Guide wire is at the front of the disc. I'll pull it back a little. So far, good. Everything's going well for this young lady. I had a nice talk with her. She's got kids, 2 of them. They're in their 30s. I said to her, she looks like she could be my daughter. She looks really young, and you can tell the people who have had back pain for years because it changes the appearance of their face. Their face takes on the face of someone in pain. And people that have had pain for less than a year, their faces don't look the same as those that had pain for over a year, 5, 10 years. Wow, that I could feel the herniation in the foramen. It's big. There we go. Yep, I went through the tear. You could feel it. It was a huge tear. So I'm going to go a little further. And then we're going to get in there and get those herniations out. Let me see. I just have to do it this way. Okay. That's pretty good.
We have a question.
I'll take it in a moment. Right now I'm very focused on this. Give me just a minute.
Copy that.
That looks good. Let me just make sure everything is where it needs to be, and I'll take the question. Why don't you show our audience while we're waiting, why do herniated disc actually cause back pain?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. Now you've seen why disc herniations actually cause back pain. And I wasn't happy with our position where we were with the disc, so I've taken the tube out and I'm going to try again. I want to get a little bit different angle. I need the needle. Wait, you don't have it? Just relax. Where's the rest? All right, just hold on. Let's just put a little pressure. We don't have to get another one. How many guide wires do we have?
Only one right now? Well, you want another one?
Actually, let's just use that stylus there. Here. All right, I'll take the questions, but I'm going to
9, 9.
basically try to redirect down to the 5-1 and get a little bit more medial because I wasn't happy with where we were. Shot? Okay, so I'm hitting the facet. I need to go just lateral. Shot? Shot? So I think there's a little bit of rotation. And the reason I'm not happy with it is because I know that the disc herniation is medial, and for me to get medial enough to get it all out or get as much of that out as I can, I need to really have a more lateral starting point. So I'm going to try to extend my incision a little bit more laterally just so I can get a little better angle. Now at some point you're going to run into the iliac crest being the limiting determinant about how lateral you can start. But I'm going to try to sneak in a few more millimeters. Shot? Because every millimeter I can gain, it gives me a few more millimeters of exposure. Shot? To the herniation itself. Shot? How's she doing? Is she comfortable? Shot? Shot? Right at the bottom of the disc there, you can see it's pretty good. Shot? I think that's going to help us. Shot? What am I hitting that's hard there? It's probably the end plate. And maybe just a little bit too low. Shot? Shot? Let's get an AP view. Sorry, Henry, did you ask me a question?
No, the question it comes from Amir on YouTube. And they ask, is there any chance of injury of spinal cord while doing surgery of the L4-5 and S1 central disc bulge by endoscopic method?
Great question. Is there any chance of injuring the spinal cord at L4-5 central disc herniation doing the endoscopic method? Of course, the answer is yes. You can injure the spinal cord from anywhere in the spine. However, there is no spinal cord down there at L4-5. It doesn't exist at that level. It's higher up. Shot? So it would have to be some very unusual circumstances in order for that to happen. What I'm struggling with is I'm sitting right on the end plate, and the problem is obviously we have a lot of dye here in this disc from the discogram, so it's obscuring the view a little bit. And also I think there's some rotational component here where 5 is rotated on S1 like some kind of scoliosis. But I'm having trouble entering the disc at 5-1, and it looks like I'm just below the tear. I want to be in the tear. So I'm going to see if I can redirect a little bit. Shot. Shot. I'm at the facet now. There it is. So I feel pretty good about that. All right, let's get the and I was able to achieve a different angle of approach or angle of attack, and I think it's more favorable now than it was before. You guys could probably see the difference in the needle position I'm starting more lateral, which allows me to go more medial in the disc, which allows me to get more medial towards the midline where the herniation, part of the herniation is. So I'm happier with this. Let's see if we can make it work. I already numbed it all up last time. Remember, everybody's anatomy is a little different. We all have a lot of the same basic structures, but everyone's structures differ in the size, the location, and hold on. Shot. Shot. Take the guide wire out, put the tube in. Any other questions for me?
No current questions.
That should be good. That's better. If we can make this work, I'll be happy. You never know until you try. With spine surgery, you can never tell all the details of what you need to know ahead of time. There's no test that gives you that kind of information, at least not available today, maybe in the future. All right, let's see what we've got. Definitely there's the herniation, and that's inside the disc. I'm going to try. There's a piece right there. Oh yeah, see how it's still stuck there? Uh-huh. There's something underneath there, but it snapped. So we're going to have to keep going and try to take out as much. Now, for those of you who've watched enough of my surgeries, you know no surgeon on earth can get rid of 100% of a herniation. It's not possible. The reason it's not possible is because to get to a herniation, you have to work through a channel or corridor. And all the corridors that are used to get to a herniation, all of them have limitations. And a limitation means that you're not able to see the whole disc from front to back. And even if you could see the whole disc, remember, herniation is not part of a disc. A herniation is outside of the disc. Oh yeah, I feel the herniation. It's coming out in pieces, but none of them are really big enough to get excited about yet. But hopefully we'll get there soon. Laser. For those of you who have not seen this surgery before, this is endoscopic surgery, transforaminal, meaning we're going through a hole already there. We're not making holes in your spine like other surgeons do with discectomies, microdiscectomy, laminectomy. They're making holes in your spine. They shouldn't be making those holes, but they do it because that's how they were taught to do it. That used to be the best way to do it, not anymore. Using a natural hole like the foramen is the best way to do this, so that's what we're doing. Now when you make these access points to the spine, they're usually limited by bones and other tissues like nerve roots or organs like kidneys and intestines and ureters and bladders and all kinds of stuff. But spine surgeons have to work around all these important structures, and they're nearby, but the surgical corridor is the path, the hallway, so to speak, the corridor we call it. It is the corridor through which you approach the problem to fix it. And all surgical corridors, whether it's in brain surgery or general surgery or cardiothoracic surgery, it doesn't matter. there are limitations to the approach. That's what they're called, limitations to the approach. The approach is the way you get there. So every approach to the spine has limitations. And the limitations of transforaminal surgery, which we're doing today, is limited by bones around the foramen. And how big are those bones? How enlarged are the joints? How collapsed is the disc? What other structures are around that we're nearby that we want to avoid injuring or coming near? Okay, so there's a lot of considerations with surgical approaches, and the old-fashioned surgical approaches, the laminectomies and discectomies, they create a lot of damage to the spine getting there. It's called collateral damage. Collateral. I didn't make this term up, it's true. So the collateral damage to the spine through a traditional microdiscectomy is massive. And as a result of that collateral damage, you get scar tissue formation, you get muscle damage, you get tendon damage, ligament damage, bony damage, instability, damage to the facet joint, damage to the capsule of the facet, and of course damage to the disc itself. So by doing minimally invasive surgery, the goal is to reduce the collateral damage caused by the procedure itself. That's the purpose of minimally invasive surgery, is to achieve the same goals or objectives surgically as you would with an open procedure, but to do it with a smaller surgical corridor and therefore hopefully less damage to the person's body. Okay? And that's why we do transforaminal endoscopic surgery like this. We do it to have less damage to the patient, but at the same time achieve the surgical goal. So the big debate with spine surgeons and other types of surgeons is, do minimally invasive approaches allow enough exposure to the pathology, the part of the body we're trying to fix, or do they prevent exposure? And the answer really depends on the surgeon's skill, the equipment and tools we have, but it also depends on the patient's anatomy. So patients with bad anatomy, like narrow foramen, big facet joints, anterior spine, all those things make the surgical approach either easier or harder on a case-by-case basis, okay? So that's something you have to understand. And as a surgeon, your job is to weigh out those influences and try to figure out what approach is best for the patient. All right, we might need the Grabzilla. Do we have it?
Yes.
I would have it in the room.
Don't all been yet? He's in the room already.
This is all part of the herniation right here. See how scarred it is? So it's really scarred down right here. I'm trying to free it up so we can get rid of it. I would say, I don't know if we need the Grabzilla, but probably we will. I mean, is there any reason we shouldn't? Let's just put it on the table.
Yeah.
And I think we're gonna probably need it because this herniation is so scarred down. So why does a herniation scar? Anybody know? The answer is inflammation. Herniation, herniated discs do cause inflammation. Let's go with Grabzilla.
Go off, lights on, please.
So let's introduce the audience to Grabzilla. Can you turn the light on so I can show them?
Thank you.
All right, here is Grabzilla. Here is the regular grabber. Look at the difference here. Can you see this, Henry?
Yes, we can.
This is the regular grabber that we use, the endoscopic grabber. It's really nicely designed, very long. It goes down the endoscope, but it doesn't have really great grabbing abilities. Grabzilla, on the other hand, is designed to go down the endoscopic tube rather than the endoscope. And Grabzilla does something very special. Watch this. It's got an articulating end so that I can aim it medially to try to grab out the herniation. So, here we go. Hey, hold this. And Grabzilla is really good for medial herniations. There's a nice, let's just show them the nice big piece of herniation. You guys see this?
Yes, we do.
Now that is not the whole herniation by any means. That's part. Okay? And just to give you an idea of how big it is, that's about a, I don't know, 6-7 millimeter piece. You guys see that?
Yes, we do.
All right. So I'm going to keep working on this for a few minutes just to see how much I can get of her herniation using this we call Grabzilla device. There's another piece. Now I'm going to go take a look again. Watch these grabbers, please. I don't want them falling. Let's go take a look. Yeah, look at that. There's a piece of herniation right there. Oh yeah. This one's coming out easier, but watch the tube. Oh, it just broke. So again, it broke. That's the problem with these herniations. A lot of them are big parts, like bellies of herniation attached to other bellies by little strands. And those little strands will break as you try to pull them out. It's rare that you actually get the whole herniation out in one piece. So I'm going to have to work on it a little more with the laser, because the inflammation that this herniation has caused in this patient has stuck it down to the annulus and the bone around it. So we're just going to have to free it up using the laser. This would not be possible without the laser endoscopically, okay? All right, questions for me?
No current questions.
So far, everything's going well for her. How is she doing? Is she stable?
Yep, stable.
Good.
Good blood pressure.
Excellent. Yeah, and to me, this herniation doesn't look older, this part at least, doesn't look older than maybe a year. So her history of 6 or 7 months of symptoms is consistent with what we're seeing in the herniation. So of interest in Florida, we just passed a law through the House and the Senate that is called the Tort Reform Bill. Oh man, that whole thing is a giant herniation. Because this bill was created or requested by the governor, Ron DeSantis. And let's get the Grabzilla again. And what he's asked for is that people that are hurt in car accidents, they typically will get a doctor or surgeon, watch your finger, it's going to come down on you, yeah, to check them out and recommend treatment. Well, a lot of times that treatment is, charges for it are really abnormally high, and we don't do that at Duke Spine. We don't take auto accident patients, but there is a lot of doctors that do, and they raise the bill. So for like a laminectomy, for example, 1-level lumbar, the Medicare rate would be $2,000, let's say, but they charge, say, $200,000. And the insurance companies, State Farm, Geico, Allstate, they're tired of overpaying for these very simple procedures. So the governor has gotten involved and basically asked the House and Senate to pass a bill that would limit the ability of people injured in car accidents to recover money for their accidents. And one of the things that they have limited is the medical bills. Other things they've done is they've limited the statute of limitations so that it's shorter. So if you're hurt in a car accident, now you have to file a lawsuit within 2 years rather than 4 years like it used to be. So they're going to make it harder for people to get money from the insurance companies. Now, for those of you who have listened to me talk about insurance companies for years, you know that I am very pro-patient, pro-patient. And if the interests of the insurance company or policies of an insurance company are adverse to patients getting the care they need, then I'm opposed to those policies. And of course, I would be opposed to the insurance company for making that policy. So in this case, it's politicians who are basically, in my opinion, making these law changes. Now, is there abuse going on right now in the auto accident world? Absolutely. Are places like, I won't mention names, but some of these spine centers that charge hundreds of thousands of dollars for a simple laminectomy procedure just to pad the bill, is that right for them to do that? No, it's not. It's unethical in my opinion. But they do it because they have a system and a scheme and they get away with it with the lawyers, okay? So now that's changing. So I do agree that there's abuse going on in Florida, and I'm happy to see that it's being addressed. But it's going to make it harder for people. There's part of the herniation. You guys see how scarred it is? All this scar tissue right here. It's going to make it harder for people to get the care they need. Okay? All right, we're going to go for Grabzilla. We're going to bring the big guy in.
Yes, please.
Here we go. We're going to see if I can grab that thing and get it out. I doubt it. No, don't move this. Don't move the tube. You can't do that. Let go. You just got to hold it where it is. Yeah, just pieces. I don't know if we shifted the tube. No. Let's go look. Yeah. It shifted a little bit. All right. Well, that is part of the herniation right in front of you. That big white wad. That's nucleus pulposus. And my goal is to try to get out as much of that as I can. Let's see. I just think it's scarred down too much. Can feel the attachment here with scar tissue. So I'm using the laser to release the scar tissue. All this is scar tissue and herniation. If I can get around it, maybe I can get a big chunk of it out, like that right there. Hope you're enjoying the surgery. We're right now at L4-S1. Trying to, oh, look at the size of that beast. That is a herniation right there. Oh yeah, there's a piece of it. But see, it keeps breaking into little pieces. And we're removing it. It's called piecemeal. Cute name. It just means in pieces. And that's how you have to remove most herniations. A lot of surgeons don't talk about it, but it's the truth. You can't get the whole thing. Yeah, this one's just breaking up. And to be honest with you, aside from the cinematic value of getting one giant herniation out, there's no benefit to the patient in getting one giant piece out. It's just, or getting it out in 20 pieces or 50 pieces. It just looks better when you get it out in one piece. But in the end, you're doing what's called a debulking, where you're taking parts of something out, little piece by little piece. That's what a herniation, that's how you get a herniation out, okay? So, unfortunately, we're stuck just taking it out piece by piece, and that's fine with me. As long as we get out enough of it, she's happy and gets rid of her symptoms. That's what matters to me. All right, any questions?
No current questions.
Let's show our audience then how the Duke laser disc repair does its job.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We're still battling this herniation. You can see it all right here at L4-S1. It's a big one. And it's requiring the laser to free it up from the surrounding bones and soft tissues. We're going to use Grabzilla.
Scope off, light on, please. Thank you.
Oh, that's a good one. Look at this here. No, it's not giant or anything, but it's decent. No.
Can you please? Thank you. Scope off, please.
This is the worst. L4-S1 is the worst. Yeah. And again, the problem for those of you that are watching and interested is scar tissue. Disc herniations get scarred. They get scarred to the surrounding annulus, the surrounding bone, the surrounding nerve root, the surrounding everything. They just create so much inflammation that everything gets destroyed around them. Not destroyed, but, you know, scarred up with sticky scar tissue. This here is the lateral part of the herniation. You have to get both medial and lateral. To successfully remove a herniated disc, you have to do both medial and lateral, inside and outside. You have to look everywhere, get it all. A little bit of fat right there. There's the posterior ligament. So off to my left here where the laser is right now, that thing right there is the end plate of L5. And the one on the other side is the end plate of S1. So we are literally end plate to end plate view right in the corner of the disc where the herniation lives. I'm going to probably bring Grabzilla in again.
Scope off, please. Lights on, please. Thank you.
Don't push down. Not bad. So again, I'm just taking it out piece at a time. Unfortunately, it's just not, the whole thing isn't coming out nicely as one big piece, but you don't, as a surgeon, you don't get to have it your way, the way you want it every time. So you gotta accept what you're given. And right now we're taking out chunks. Each one of those chunks probably 10% of the total volume of the herniation. So every big chunk we get is about 10%. I could try one more right there. Let me try one more right there. The Grabzilla is the most effective tool for this particular type of herniation at 5-1. It's rarely needed at other times, but I could feel it. Oh yeah, I could feel it that time. Look at this thing. See this?
Yes,
That's a big piece right there of the herniation. Well, sometimes you get lucky when you get a good grab on the herniation. Watch your finger. And you can actually, it shifts it and pulls it over so you can get more of it. But really it's, I mean, I'm telling you all the secrets here. Neurosurgery is not, this kind of neurosurgery is not that hard. Okay? Once you get all the right equipment in all the right places, you know, it's pretty straightforward. The key is preparation, getting everything just perfect as you can make it, at least. You know, getting the right corridor, the right approach. Even though we stuck the Grabzilla in, look how much of the herniation is still there. We just couldn't get it. So let's try this one. Yeah. Oh yeah, that was pretty good right there. I can't even grab it, it's so big. Big and firm. Remember, the inside diameter of this is around 5. Oh God, yeah, I feel it. Ah. Do you feel it? Do you feel the body move? That's a beefy. There's something there. I could feel like kind of when a rocket launches here. I cannot grab it. It's so big and so firm. Well, let's try Grabzilla one more time.
Lights on, please. Scope off. Thank you.
So I was saying the inner diameter of the tube you're looking through is literally about 5 millimeters. So the view you're seeing with the scope is highly magnified. Looks big, but it's not. All right. So probably 5 more minutes on this one is what I'm expecting. And then we're going to move to the L4-5. You see all the little pieces of herniation floating around everywhere.
Our first case today is doing great and went home.
Yeah. I saw our first patient. He was doing very well. Went to his hotel, right? He's from California. We have a lot of people from California coming here from other states in general, but California in particular. A lot from the Northeast, Boston, Maryland, Philly, New York, New Jersey, huh? We have, from where? Oklahoma this week, yeah. I just talked to her, as a matter of fact, on the phone. So everybody heals differently from the surgery. The actual muscle spasms you get after the surgery from, you know, being in the muscles for the surgery, putting that tube in. We're passing through the muscles in the patient's back. And of course, the muscles are going to be angry and sore. And in some people, those muscles take longer than others to heal. But it's not uncommon to have 10% of the patients with muscle spasms after surgery. It just takes time for them to settle down. A lot of people who have back pain, they don't use their backs like they're supposed to for a long time, and what that does is it causes the muscles to atrophy or get weak, basically. And then when they start doing stuff, they have a straight posture, for example, their muscles don't last to hold them in good posture. They get tired. They're deconditioned. All right, let's get the grabber. Try to grab some more of the herniation out from this corner. So far, everything's going really well for this patient.
And we have those patients that have an active life or a busy career, and then they lay down a lot because of their injury, and then they're not moving as much as they used to.
That's correct. Yeah, so muscles are not something we can fix with surgery. There's no surgery to fix deconditioned muscles. Okay? That's why it takes hard work in the gym. Right? You gotta physical therapy, gait training, reconditioning, core exercises. There's a lot that needs to go on. But what I find is that people's back muscles will generally get strong over time if you just have them stay active. Another piece of herniation there. The key is just stay active. Don't lay around in bed. You know, get out and do things, but carefully within the restrictions.
Walk 20 minutes a day, twice a day, right?
20 minutes twice a day. We tell everybody first 2 weeks after surgery. 20 minutes twice a day. All right. We're getting there. I'm starting to see we've removed probably 60% of this herniation by now. Little bone spur there. People ask me, can you get rid of bone spurs? Yes, we can, very easily. But we don't get rid of all the bone spurs. There's no reason to. I'm not going to go taking someone's bone spur out when the bone spur isn't doing anything. Let me ask you a question. Are you going to go fish all the sharks out of the ocean? Right? No. But you don't want sharks where you're swimming. Okay, so do we need to take all the bone spurs out of somebody's body? No. Most of them aren't harming anything at all. And bone spurs are your body's way of trying to stabilize a joint. It makes bone spurs. So there's no reason to take all the bone spurs out. Some people don't understand that concept. All right, grabber. Just about done. I'm reaching up kind of to that paramedian area where the herniation was the biggest, trying to get out as many of the pieces as I can. I'm literally debulking it little by little. There's some more pieces, right, of that herniation. Just little pieces. Of all the herniation types, this is the most annoying because it literally comes off in little flakes. Each of those flakes, probably 1% of the herniation size. There's a nice chunk. None of them really that gratifying, but collectively, together, substantial. Oh, I keep thinking I'm getting a tail of something big. It's like fishing, right? Hoping you're going to catch something big. Any questions, comments, concerns, or criticisms?
No, nothing. No current.
Nothing.
No current
Are
questions.
we even streaming?
Yeah. Yes. Of course. I make sure.
Remember we used to have that anesthesiologist that would come on and criticize my surgery. That was really. Were you here for that?
No.
You weren't here for that?
The way you're telling it's kind of funny.
Oh man, it was funny as hell. You remember Henry? He was some anesthesiologist in, like, I want to say India or Iran or something like that.
Yes, yes.
Yeah.
It was around that area for sure.
And he would be like, no, you're not doing that right.
Oh my God, yeah.
For the record, Henry, I have no concerns or criticisms. I just want to
Appreciate that. Oh yeah, he was.
really like critique how you were doing the procedure.
Oh God, yeah. And I said, what kind of doctor are you? He said, I'm an anesthesiologist. I said, okay. So you're an anesthesiologist who wanted to be a surgeon and just couldn't make it. Uh-huh. I know your type. Phew. I just want to get a little bit more. I'm almost to where I'm happy. Remember, we're not going to get 100%. So for those of you saying, hey, shouldn't you get 100%? No, nobody gets 100%. Have you ever gotten 100% of anything? 100% of the food, 100% of the whatever. I don't know anybody that gets 100%. It's just not possible. Maybe Luis could do it. No? You sure? Maybe the anesthesiologist could do it. Right? That guy. I miss him. Are your patients good? Yeah, this is just taking a long time because, well, let's just face it, it's a big ass herniation. But I'm getting to where I'm starting to see pulsations. It's something we look for, pulsations. And the reason why we're looking for pulsations is what's pulsing is the dura around the nerves. That's what the herniation was pushing on. The nerves. And when you start to see pulsations, it means you've gotten enough of that herniation out that the dura and the nerves are now pulsing, meaning that they're not squashed so bad. Is that even a word? Squashed? Crushed? Squashed? Squashed so badly. They're not squashed so badly anymore. Oh, come on, get out of there. Just about done. Let me just look. I might get just a little tiny bit more and we're done. Probably 5 minutes at this point. Now I have to admit, this surgery can take longer than a microdiscectomy, but then again, it's a more delicate surgery. And most of the time it takes less time than a microdiscectomy, but big herniation like this, it can take more time. About 90% of the laser surgeries are faster, shorter than a microdiscectomy. About 10% of the time it takes a little longer. All right, let's see if I can come back a little more. There's our epidural space. That's the back of the disc. All right, anybody have an interesting story since our audience is not asking questions at this time? Anything interesting in the news? Luis?
Now that I know.
No? I heard that Elon Musk was writing letters to his employees at 2:30 in the morning, talking about how they can't work from home anymore. All right, grab her. So I'm grabbing now, I'm not really getting anything, which tells me I'm coming to the end of this. What typically happens with a herniated disc is moving pieces of it, and the top, the roof will start sagging down because you're pulling out pieces of it from below. And so the roof will sag, and you'll be able to get more of the herniation over time because the roof is sagging, and at the roof is where the bulk of the herniation is, right? So at this point, there's no more sagging happening because there's really not much herniation left. And when I put my grabber in there, I didn't feel any more herniation either. I'm going to come back a little further. There's all right, last grabber. Let's see if I can get any of that. I have a feeling that we're done. Little pieces. Nothing really substantial. I'm not feeling any big pieces anymore. Two minutes. Wonder if I should put Grabzilla in there one more time. Give me the laser. See that cluster of inflammatory tissue? I want to try to clean some of that. We've gotten out a fair amount of disc, and it's important as a surgeon that you try to pay attention to how much of the actual herniation you're removing. You've got to look at what we call the debris, which is the pieces of herniation sitting on the operating room sheets next to me. And if you have a good amount of debris, which I do, that gives you an idea of the volume of herniation you've removed. And I'm looking at that constantly, thinking about it. Let me have the Grabzilla one more time.
Lights on, please. Go ball. Thank you.
Let's see if Grabzilla can do anything for us. No, don't move that. Don't move that. Not much. Not much of anything.
Scope on, please.
On scope. Yep, I don't see any more. I think that's just scar tissue. I don't really see any more herniation. We've created a nice cavity.
Lights on.
The nerve root's right there. You guys see it? You
Yes,
guys
we
see
do.
the nerve root?
Yes, we do.
It's literally the top half. That's the bottom edge of the nerve root. It's got a little vein on top. You see how the vein fills with blood when I twist it? And maybe I'll get a little bit of the herniation here, laser, just to make sure I get all the pressure off the nerve. So this is just below the nerve root. It's some of the annular tear. I don't see any herniation in it. And I'll just switch the other way. I want to make sure none of this has any herniation in it. It's just annular tear. So you can see the difference. Look at the annulus there, the white thing there, versus the nerve root up there. Right there, that's the nerve root. And you can see the bottom edge of the nerve root right here below the laser. It's a little bit of tissue in front of it, but that shows you the relationship of the herniation to the nerve root. Okay? And this surgery, we're preserving the nerve root. We're protecting it outside of the tube while I'm working on the herniation. All right. I can't get any more out. I've done the best I can. I'm hoping we've gotten 60%. That's what I'm thinking. And if I'm successful at that, the patient will have good relief of her pain. I've never had anybody not get good relief with one of my surgeries, but there's always a first. And you never know who it's going to be. So for her, I feel really optimistic that it's going to work very well for her. I feel like I did the very best I could, and I feel like it's going to be good enough for her to give her many, many years of relief. But we're not done with the whole surgery. We just finished the L5-S1. So we're going to go to the L4-5 next. So coming out with my tube, put a little pressure on the muscle. Remember, muscles can bleed a little bit, and if they do bleed a little bit, you want to minimize that bleeding by putting pressure for a few minutes. What that does is it prevents too much blood from getting in the muscle, which the blood will definitely irritate the muscles after surgery, causing muscle spasms. So sometimes patients will have some muscle spasms in their muscles after surgery that can last a month, even 2 months. I've seen it last up to 2 months in a patient. And, you know, we try to reduce the amount of muscle spasm and blood by, you know, keeping the blood pressure down to we're in a safe area, you know, around 110, 120 systolic, and we put pressure. You're not stopping it. And by putting pressure, it allows the vein that's torn to close up. Shot? Yeah, so shot. You can see the x-ray picture. There's a guide wire now at L4-5 shot. And you have to be careful because sometimes when you take the needle out, when you're taking the needle out, you'll actually pull your guide wire out too. You don't want to do that. Pulling the needle out and pulling the guide wire out at the same time is a faux pas. It's not something you want to do. You want to make sure you keep your guide wire in there. Shot. Let's give it a little num-num. Phew, my dogs are starting to bark. Got it. I notice when I hand instruments to Luis, I'm going to show you something. Let me have that needle back. If you're ever a surgeon and you're working with people, you want to avoid stabbing somebody. So the surgeon's supposed to hand things to the assistant's supposed to reach for them. But if the assistant reaches incorrectly, let's show the incorrect way, just reaching, I can stab him accidentally, right? If I'm looking somewhere else, I'll stab his hand. So the way you're supposed to hand off a sharp instrument is you hold the sharp tip away and you hold it steady. So let's show you one more time. Luis is going to wait for me to stop. Just wait for me to stop. I hold it here, and now he can gauge the distance so the two of us aren't moving towards each other. So there's predictability to the movement. And I leave it up to him to make the determinations. And so I move it close enough to him, and then I stop. I move it to his zone of reaching, and then I stop and I let him finish the movement. And that way he can, you know, keep his eye on it and make sure that he's not he's not going to get stuck. Go ahead. So you don't want to stick your partner for a lot of reasons, but needle sticks, sharp sticks in the operating room can transmit diseases from the patient to the personnel. And so, remember, there's a lot of nasty things transmitted through blood and other body fluids. Hold up. Everything okay?
Yep.
So when I'm doing this with Luis, I want to make sure I don't accidentally hurt him or Oscar. Oscar, I don't care as much about. I'm just kidding, dude. I care about everybody equally here. But the point is that I'm trying to make a joke. Oscar, you should have seen your eyes, man. They were like going to pop out of your head. I'm kidding. But seriously, transmission of infectious agents from the patient to staff is very serious. That's why universal precautions were created. And we follow those universal precautions with everything we do. And you want to be careful not to poke somebody or poke yourself in the operating room. So a little bit of, there we go. All right. Now we are at the left L4-5 disc. Remember, we finished the 5-1. I'm satisfied with 5-1. I didn't get all of it, but there's no way to get all of it. All the herniation, that is. But I feel like I got at least 60%, which is going to be enough to get rid of her symptoms for the rest of her life and let the annulus seal over. The important thing is you saw the annulus is debrided. There's no herniation left in the annulus, and it can make a nice seal, close off, so that you don't have more herniation. The biggest problem with microdiscectomy is that microdiscectomy procedure doesn't allow sealing of the annulus. That's why they have things like the barricade device, where doctors, after a microdiscectomy, are putting in this piece of metal, like a metal gate, but it doesn't work. I would not recommend it. Let your body heal naturally the right way. You don't need a barricade device. Of course, the venture capitalists that spent the money on the barricade device, they want to see a return on investment. So in their opinion, you need the barricade device, but not in my opinion. Now, there are a lot of doctors putting that barricade device in. And I've seen so many patients that have had it done, doesn't work. They're still in pain. They get all kinds of problems from it. I don't recommend it. This is all the blue stuff you're seeing, by the way, that I'm zapping away is degenerated disc. You guys have heard the term degenerative disc disease. Well, this is the degenerated disc. This is how you get a degenerated disc. The nucleus degenerates. And that comes from inflammation inside the nucleus, inside the tear.
No current questions, but we do have a comment from Billy54 on YouTube.
Hi, Billy. Thank you.
And they said, here's a story. In 1973 through 75, Dr. Williams in Vegas did 500 herniated disc surgeries through a 1-inch incision using a microscope and small micro instruments to enter the disc. No laminectomies. He removed the herniations with very little blood loss and no bone loss. He was a pioneer in micro back surgery. Like you, he was not widely accepted because laminectomy was what they all did.
Yeah. Yeah, great question. And I didn't get his name. Dr. Williams, you said?
Dr. Williams in Vegas, yes.
Interesting. I would have loved to, you know him?
What year?
What, he said 74?
73 through 75.
Yeah. Dr. Berndes worked in Vegas with a lot of the surgeons out there. I asked if he knew him, but he wasn't working in the 70s. Yeah, I was about 3 years old at the time, still in Germany. And it's great to hear stories like that. I would like to look him up. I wonder if he ever published any of his work. But smart man. Laser?
His name is Dr. Dr. Robert William, MD.
So you are correct. All the spine surgeons that I've ever trained with, known, they all get to the disc through the laminectomy until I went and trained with the Koreans and German and Dr. Young, Anthony Young, over in Phoenix. And they were using this transforaminal approach coming through the foramen. Now there is another surgeon that we kind of give some credit to for this approach before Dr. Cambin, Parvis Cambin, and his name was Wiltsey, and it's called the Wiltsey approach. And what it was a paramedian, like in a big incision, but it was to the side of the spine, about 2 finger breadths off of the midline. And it was really an approach only used for foraminal disc herniations. Foraminal disc herniations, which are rare. I mean, at least we thought they were rare back then. So it's called the Wiltsey approach. It's a muscle splitting, fascial splitting approach. But you're right, it doesn't remove any lamina or bone. You come from outside the foramen. So outside the facet joint, basically. And we learned that in my training, and we used it once, I think, in 7 years of training. So it's very rare to use it. But it sounds like this surgeon in Vegas used the Wiltsey approach to do these surgeries, and he probably was very smart about it. He realized that there were advantages to going transforaminal. Then, of course, Dr. Cambin really is the one who is credited with coming from far lateral and modifying the Wiltsey approach and coming, instead of paramedian on the side, 2 finger breaths, he went like a 10 finger breaths or 7 finger breaths to the side. So he really took it very far lateral. But great, yeah, pioneers in any field in medicine are good. I mean, we need pioneers because we want to improve the outcomes of medicine and healthcare. If you want things to get better, you have to pioneer. Like right now, we don't have cures for cancer, for example. A lot of cancer is uncurable. We need pioneers to figure out ways to cure cancer. Diabetes, the same thing. Man, if we could find a cure to diabetes, wow, how amazing would that be? But it's going to take a pioneering approach. The problem is, and yes, the patients can value it, and they want it. They want these pioneering technologies. The problem is getting insurance companies to pay for them, because insurance companies are for-profit businesses. They make profit. They want profit. And the way you get a profit in healthcare as an insurance company is by not paying claims, just like every other insurance carrier. If an insurance company pays too many claims out, then it doesn't make a profit. It literally doesn't make a profit. So insurance companies make profit by not paying claims. So insurance companies are always looking for a reason not to pay claims. And the only reason in healthcare that they're allowed to not pay claims is if they call something experimental. And so that's what they're doing. They're calling things experimental so that they don't have to pay for it. You see, whether an insurance company has to pay for somebody's medical care or not is determined by the law. And laws allow insurance companies to get out of paying for claims as long as that treatment they're supposed to pay for is experimental. So insurance companies now are claiming all the surgeries and all the treatments experimental. If you try to get an MRI scan done for back pain, they're going to tell you the MRI scan is experimental. And what they mean by that is that, yeah, the MRI itself is not experimental, but the fact that you're doing it for back pain is experimental. It's unproven. So it's not true, though. That's just what they're saying. But they realize if they don't pay for your MRI, they're not going to need to pay. They're not going to have to pay for surgery, because you can't do surgery without an MRI. So they're very deceptive in their approach to patient care and in terms of authorizing treatment. So I'm glad you mentioned about this doctor in Vegas, and I'm sure he struggled because his technique was probably not paid by insurance companies, or they tried to get out of paying it, and ultimately, even though it was a better idea, a better way, it didn't catch on because of a variety of reasons, one of them being reimbursement, but others being, not being mainstream. I will tell you this. I truly believe that there are forces at play that are trying to ultimately push patients to fusions. Fusions of the spine, artificial disc fusions. And I think that those forces, which are the companies that make the fusion devices and the barricade devices and the spinal cord stimulators, all these implant tech companies, they want laminectomies done because laminectomies create instability and people go on and need fusion done later. So they're banking on the laminectomies to make things worse, and people will then be recommended for fusion surgery. 3 minutes, maybe 2 minutes, almost done. You guys can see the tear, right? Right here. You see the fibers there, the white ones, they're torn here, and there's this nuclear material here that I'm cleaning out, right out of the tear. Okay, just about done. There's some blood vessels in the epidural space. You see the veins right there? Looks like a hemorrhoid, but it's not. That's called Batson's plexus. There's some fat cells. Each of those little white lights, little yellow lights on the fat, is a reflection of light off of a cell. So each one of those is a fat cell. Just to give you an idea of the scope here. Last of the herniation. Nice clean tear, by the way. You see that? Here's still some normal annulus right here. You guys see the fibers intact? White, attached. This is normal. And then right here is where the tear was. And I've cleaned the tear out nicely so that this tear will heal. 30 seconds. Now you all know what the tear looks like. That's it. We're done. Let's hope it works for her. All right, if you have any questions, type them up, and I will take them. In a few moments, I'll take your questions, so go ahead and type them up. And you guys can see how small the incision is. This is some betadine to prevent infection. I'm going to show you the incision that this whole surgery was done through. 7mm, 1/4 inch coming in. You guys ready? You can see it was done on the side. So I'm putting a little bit of pressure just to make sure there's no bleeding. You guys see the camera here?
Yes, we do.
All right, we're going to put a bandage on. Let me just check, make sure there's no bleeding. You guys see that?
Yes, we do.
So we'll hold pressure just for another minute or two, and then we're going to put a Band-Aid. All right, you can go ahead and cut to a testimonial. And I'll come answer your questions, so type them up, please. I'm Dr. Duke Machen here at the Duke Spine Institute, and it is a beautiful January 26, 2023. And I have with me one of my patients who's traveled from Michigan.
Actually, South Carolina. I'm from Michigan.
Originally Michigan, from South Carolina now recently. You had surgery just yesterday.
Correct.
How do you feel today?
Awesome. No pain where the pain was in my vertebrae is gone.
How long did you have that back pain for?
38 years.
Wow, 38 years. So you remember to the year.
Well,
how long
because
you've had it.
I remember lifting up an engine and hearing my back explode like a shotgun. and I went down on the ground, and you know what happened after that.
So for 38 years you've lived in pain, you were in the military, and why didn't you get it fixed sooner?
Well, I went to Walter Reed to have a neck fusion. I had a really good doctor there who knew I had back problems, and he asked me, he said, you should wait until there's a doctor or some sort of procedure that you won't have to get the fusion and fix the problem. And he was correct.
So you waited, and how did you find out about Duke Spine Institute and the Duke laser disc repair?
So I watched Newsmax, and I saw another gentleman that does similar work that you do, and I looked at his stuff, and then my daughter's a nurse practitioner, and we said we should look and see if there's somebody else out there to talk to. I found you. I was impressed after looking at your website, seeing your procedures and how upfront you were with everything. It was a no-brainer.
And here you are now, sitting in the chair, giving your own testimony.
Exactly.
What was life like for you living with back pain before we did the surgery yesterday?
Oh, it was terrible. It was debilitating. The things I like to do, I couldn't do. You know, like picking things up. I mean, I like to do that. I just like to be involved in everything, and I couldn't do it.
So you would limit what you did because of the pain?
Absolutely.
Because you were afraid to set it off?
Correct.
When did the pain in your back become constant?
Probably 25 years ago. The injury, at first, you know, they did some ice massages and different pain things for it, where I was able to finish up my military career. Being a mechanic by trade, if I bent over, I had to go to a sitting position straight up, because I would just lock up. And then there'd just be days I couldn't get out of bed because my muscles would just contract so tight that I couldn't move. And I'd have to go see a chiropractor, or I'd have to go get a shot. I'd have to do something to be able to start moving again.
And the mistake a lot of people make is they think the muscles are the cause of the pain, but it's not. They're reacting to the disc pain.
Right.
You can see the disc is actually the cause of the pain, because we discovered at Duke Spine Institute there's a tear in the back of the disc that causes the pain, and that tear gets filled with jelly that's trying to escape from the center of the disc, and we call that a herniation. Anyway, it can happen with bulging disc, herniated disc, protruding disc, ruptured disc. All of those injuries to the back of the disc can cause this back pain. And now the back pain you had before the surgery is gone.
Yes.
Completely.
Yeah. And you got a chance to see I've got a complicated medical history, if you would, with injuries and such. And to be able to use my back again just makes life so much better.
Absolutely. Now, you have a special history with your back, don't you?
Yes.
You have tattoos back there.
I do.
And you have won some awards.
I have.
Can you tell us about that?
It's a funny story, but I used to ride motorcycles, and someone took my motorcycle jacket that had all my stuff on it. So I went to a friend of mine who was in the military, and I said, here's my DD-214, put it on my back so nobody can steal it. And so you see my whole my whole military history for 21 years is on my back. Every place I was, whatever I did. It's pretty intense.
You're very proud of your back because it represents the history of your life and your accomplishments. And we went and we fixed your back. So now you can display it without pain.
And I'm going to add a new medal. And the medal is going to be the Duke Spine Institute.
Duke Spine Institute logo.
That's it.
Yeah, that was our agreement. If I fix his back pain, he puts the Duke Spine Institute logo on his back, because he said that the back is the story of his life. His tattoos are the story of his life, and so this is a big chapter in his life. It's the rest of his life without that pain.
That's right.
Yeah. And so if you watched the surgery, you could see his beautiful tattoos, and we did everything we could to preserve them. We went in with the laser, and I cleaned out those 3 discs, and it turned out all 3 of them were causing severe pain for you. And we successfully debrided the tears and the herniation using the laser.
I saw that.
It went perfect, and didn't have any problems with it. Anything you want to say to your fans out there?
I do. Anybody that has back injury, if you haven't checked out the site, his website, please do. Take the time, and if you want to get your back fixed, come see him.
Well, I want to thank you for your service to our country and congratulate you on the faith that you had in having us help you.
Thank you very much.
You're welcome, sir.
Thank you.
I hope you enjoyed that testimonial. It's always good to see people getting out of pain. Duke Spine Institute specializes in getting people out of back pain, out of neck pain. That's what we do. And it turns out that around 83% of patients with chronic back pain the pain is actually coming from a damaged disc, an injured disc. And specifically the back part of the disc where there's a tear. We call that a posterior annular tear. And it's really the posterior annulus that's torn. And that's why we specify it as a posterior annular tear, because there are tears that happen in the front as well as the side. And this patient that we just finished, she came to us literally, if this is a normal posture, she's walking around like this. She cannot even pick her back up. Now, is there something wrong with her, like musculoskeletally? No. The reason why she can't stand up is because every time she stands up, her herniation pinches her sciatic nerve, and it causes the pain to shoot down her leg. It causes horrible back pain. So I identified 2 discs as being the cause of that, L4-5 and L5-S1. The L5-S1 had a much bigger herniation. You could see it on the MRI. It was a beast. And the problem is that getting to the L5-S1, it's the hardest one for me to get to, and anybody to get to. As a matter of fact, of all the endoscopic spine surgeons in the world, and there's probably only 100 of us, nobody else tries to get the L5-S1 except for me. And what I mean by that is transforaminally. They usually do translaminar, so let's start drilling your lamina out, your bones out. But what I do is I come from this little tiny corridor right here, okay? And I'll leave that in there for a moment so you can see it. But you could see how tight that is. And when you have a collapsed disc, right, so things are shifted even worse, it's really not much room to get in there. You have to really work around the facet joint, the transverse process. There's an iliac crest here you don't see. And then, of course, getting right in there perfect is what you have to do. So we were able to do that today. And I felt like we were able to get at least 60% of that herniation out, which is, the target is 50 or more. And really I try to get 90, but I just don't think that's possible in everybody. So I think we probably got 60 to 80%. And the way I'm going to gauge my success is how the patient does after surgery. I don't use MRIs and X-rays and CAT scans and other kinds of what we call surrogate markers. What matters in the end is the patient and how they feel. And so if the patient's happy with the results, then I've succeeded. If the patient still has pain in their leg, then I've not succeeded. And of course, some people have pain in their leg for other reasons other than a pinched nerve. I'll give you an example. We did a laser surgery on a patient about 4 months ago, and he was from Louisiana. He had 5 bad herniations. We got all 5 done. It was really a hard surgery. And the patient had some facet pain. About 2 months after the surgery, he called me and said, hey, you know, I've got pain in my leg. And I said, okay, let's see. And he was showing me his leg, and he said, yeah, it started swelling up just lately, like the last couple of days. And I said, you better go to the emergency room. You might have a blood clot in your leg. So he went to the emergency room, and they said, nope, there's no blood clot in your leg. And I guess I said, well, this just doesn't make sense. So he went to a different emergency room. A few days later, they did another scan, and sure enough, he had a blood clot. So his complaints were leg pain and swelling, and it just didn't make sense that it was a pinched nerve. I knew it wasn't a pinched nerve. I knew there was something else going on just by the description of the pain. It was mostly below the knee. It was a burning kind of pain. It didn't sound like a pinched nerve to me. And it wasn't. It was a blood clot. Of course, if the doctor doesn't make the right diagnosis, the patient can die in that situation. So when you have a blood clot in your calf, you have to get it on Coumadin, which is a blood thinner. There may be another drug now they're using, but they put him on Coumadin and he's doing okay. Point is, not all leg pain comes from a pinched nerve. There's other causes. And it's important that the doctor figure out why you're having it. Some people have more than one cause to their leg pain, but most people just have one, fortunately. All right, what questions do we have?
All right.
let's go with the question for right now, and this comes from Oz on YouTube, and they ask, can there be a disc injury or aggravation if you compare a pre-injury MRI to a post-injury MRI of the lumbar and they look identical?
Yes. So Oz, you bring up a great question that we deal with all the time, especially in the medical legal world where we're looking at patients who've had accidents or work comp injuries, is that the patient may have no symptoms whatsoever, normal, no back pain, no leg pain, perfectly healthy, working every day, doing all the stuff they like to do. Then they get into an accident and they've had an MRI before, they have an MRI after, they look the same. Could the accident aggravate a pre-existing disc herniation or injury? The answer is yes. That happens all the time. And we see it all the time. So remember, we don't treat MRIs, we treat symptoms and signs. Signs being weakness, numbness, things that the patient may or may not complain about, but that we find that on exam. So when I'm examining a patient's foot and I'm pulling on their foot, are they able to keep the foot up strong, or can I pull it down? If I can pull their foot down, then there's weakness. If there's weakness, that means there's a pinched nerve. You can ask a patient, you have any weakness? And they say, nope, I'm fine. And then you pull on their foot and they have weakness. And then they go, oh wow, I had no idea I had weakness. That's right. Because at some point, you start to, it gets bad enough you recognize there is weakness as a patient. But until that point, you don't recognize the weakness. Same thing with cancer. You have cancer in your body, it's growing there for 6 months. You may not know you have cancer. You may not have any signs or symptoms of cancer. And then after 6 months, you start getting nauseated, or you have fevers, or you're losing weight, and then you're like, wow, something's going on, and that's when you realize there's a problem. But that cancer was there long before that. So herniations can be there for a long time, many years, and people don't know they have one because they have no symptoms. And then they get into some situation and they start having pain, and they've aggravated that injury that's already there. So the MRI may not look any different, but remember, I've told you guys this before, it's the inflammation that causes the symptoms 98% of the time. So don't look for structural changes, because MRIs only show structural changes. What you're looking for is a physiological change, which MRI cannot show, and that's the inflammation.
All right, and then next we have a comment from Billy54 on YouTube, and reprising from what he said about Dr. Robert Williams, there is an article on PubMed that you can look him up, from Robert W. Williams, Forgotten Pioneer of Spinal Microsurgery. Dr. Williams found his, or either PubMed or SpineMed, I think. I have an old copy of his technique brochure and will send it to you. Dr. Williams found his work was received cautiously with significant skepticism. He found the orthopedic spine surgery community in journals more receptive. Thus, much of his earlier work was published in the orthopedic literature.
Interesting.
Interesting career and contribution to spinal microsurgery is outlined, demonstrates the contributions to both neurological and orthopedic that can be achieved by a neurosurgeon in private practice.
Yeah, you're right, Billy. And I guess I'm one of those pioneers, just like the doctor, and I've experienced a lot of the same issues. Going against the establishment, very difficult. You would think that my work, because it's so significant in terms of patient outcomes, would be received very well by neurosurgeons, but no. And the reason is because you're going against the establishment, and I've thought about this for a long time. Unfortunately, the establishment is controlled by companies with special interests that are not neurosurgeons, but control neurosurgeons that control the establishment. So the companies that, for example, manufacture metal to go in your spines, they literally sell $50 billion of metal a year worldwide, and into the spine. And if all these surgeons suddenly stop doing metal surgeries like artificial disc, fusions, whatever, then all that money would go away. And the companies that are making those billions of dollars a year selling spinal implants around the world, they do not want their business to go away. They don't care that the laser surgery we do is better for patients. They don't care that not fusing people is better than fusing. They don't want that ideology, that practice to be out there. They are completely opposed to it. It's more of a cult, and it needs to be exposed. And I feel like your doctor that you're advocating and championing for, which is wonderful to hear. I hope someday, long after I'm gone, my patients will champion for me. My web team will champion for me. Henry will champion for me. But my point is that pioneers who go against the establishment because they have something that's better for patients are true heroes in society. And we need more of them, more people willing to stand up for what's best for the patient in medicine, okay? And we don't have enough of them. We have too few shepherds and too many sheep among the doctors. And we need more sheep to turn into shepherds and to identify better ways to practice medicine that are better for the patients, not necessarily for companies or hospitals or societies, but better for the patients. And that's what my dad taught me to do, because my dad was a doctor when I was just a kid, 4, 5, 6, 7, 8 years old. And I remember what he taught me, and I never forget it. And it was always do what's best for the patient. So when I start to see this path split in neurosurgery, where this was better for the patient, but this was better for being a neurosurgeon, being a doctor, making more money, being part of the clique, the group, walking the line, towing the rope, I realized I didn't care about these things as much as I cared about having patients that had great outcomes. I fixed their problem for them, and they went on to have a normal life. That's why I went into medicine, was to take that path. And it's unfortunate that there's a divergence and a lack of support. But I'll be honest with you, when I started doing these surgeries 16 years ago, I went back to my own residency program. I spoke to my chairman, Dr. Friedman, and I spoke to Dr. Friedman, Dr. Roten, Dr. Day, Dr. Roper, Dr. Jacob, and my own faculty did not support anything I was doing in any way. They weren't against it, but they didn't support it. And it's really hard to make a new technology widely distributed, available, without support from somebody in such an industry as neurosurgery. And what bothered me the most, perhaps, was Dr. Friedman, the chairman at the time, because he sort of laughed off my endoscopic spine surgery. And I'll tell you, he one time said to us as residents at the VA hospital where he was the attending, he one time said, "We will fuse anyone who will lay down an operating table for it." Why? I'll tell you why. Because the company Medtronic that was making the screws and rods for the fusions, they were giving millions of dollars to the Department of Neurosurgery for research and education, money that he controlled as a chairman. Okay? And that ideology of we will fuse anyone who will lay down for it is what's happening right now throughout neurosurgery. Neurosurgeons will fuse anybody that will lay down for it. And they'll make a lot of money doing it. and they will generate a lot of money from these companies that sell the screws and rods for doing it. But it's wrong for the patients in the end. That's who I have a responsibility for. One last thing about Dr. Friedman. What shocked me as well was that Dr. Friedman was a pioneer himself with something called radiosurgery. It's the use of radiation to treat brain tumors. You see, for 100 years, brain tumor surgery was always brain tumor surgery. You turn a flap, you take the skull off, you open the dura, and you go in and you remove the brain tumor piece by piece. And then there were a few pioneers, Swedish neurosurgeon, for example, that realized you could direct radiation to the brain tumor and not have to open the skull. You could just radiate it. And that if you took one beam of radiation and shot it through the skull, you would destroy everything here, the skull, the skin, horrible, horrible complications from radiation. So he realized, well, if you shoot one beam here, 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 60 different points, that they all converge in one spot. And that one spot is where the tumor is. That you could give the tumor a dose of radiation that would kill it without destroying the outside of the patient's head. Hence, radiosurgery was born. Dr. Friedman was a pioneer of radiosurgery with linear accelerator radiosurgery. He was shunned by neurosurgeons all over the world as he was promoting stereotactic radiosurgery for the treatment of brain tumors. Okay, he even had patents on the development of collimators for radiosurgery treatment. So he, of all people, should have understood what it was like to try to develop new technology that was better for the patient in the face of overwhelming opposition from his colleagues. And yet, when I went to him for support, he gave me none. So yes, it didn't make me stop. It didn't scare me and turn me away. In fact, it made me angry that the priority in healthcare is not the patient, that it's egos and money and all kinds of other things that don't really matter. What matters is the best result for the patient. So I stayed focused for 16 years. I worked hard with my team. I have my web team here getting ready to have a meeting with me, and everybody around me that I've brought to Duke Spine has the purpose of sharing knowledge and information about what is now available in the patient's best interest, what can be achieved today for you, the patient suffering, without having to succumb to invasive treatments, screws and rods treatments, and all kinds of special interest groups that just want something out of the patient experience other than to give the patient the best experience. So we're true to form. That's our purpose, our mission. And you guys need a purpose and mission, right? For the website. But thank you for sticking around, and I think this patient will do fantastic. She's going to go home in about 15 minutes. Any other questions or comments?
We have a lot of comments and questions, actually. Well, the one question, I think we just ended at that. The question is from Oz on YouTube, asking, when are you bringing back those old school surgery scam episodes?
The old school surgery what?
Like spine scam.
Oh.
Yeah.
Oh, thank you, Oz. That means a lot to me. We produced video footage with one of my prior videographer editors, and we did Spine Scams Exposed, where we would highlight all these spine scams, you know, artificial disc and laminectomies and stuff. When are we going to bring them back? Soon, I hope. But you know, I think it's great that you appreciate it. They're very educational, I think. I will work with Henry on making some more.
Yep.
All right. But I will let you in on a little secret. My goal right now is to create a full-length documentary on the spine industry and to expose to the public the corruption of what's happening at every level in the spine world. And I've already been in talks with a Netflix distributor who has an interest in this topic because it has tremendous public value for people to know what's going on. Because so many people have back and neck pain, so many people are getting suckered into majorly invasive surgeries, and it's only getting worse, only getting worse. I see it happening everywhere. I don't see it stopping. It's like an avalanche coming down the hill, and it's heading towards a village. And people are getting hurt from these treatments, and the world needs to know about it. So that will be our Spine Scams Exposed. It will be hopefully someday a Netflix documentary that you can watch, and or maybe a series. We'll see. But right now it's in the ideas in its infancy. But thank you for asking. All right, we're going to wrap it up, and we'll see you all not next week, but the week after. Next week I'll be out of town, but I'll be back the following week, and we have a lot of surgeries going on the following week. We have some really interesting cases, cervical herniations, lumbar herniations, thoracic herniations, Duke plasma rhizotomies for facet pain. So it's going to be a busy week when we come back. So enjoy yourselves, and we'll see you soon.